Welcome, everyone, to the update on the management of elevated lipoprotein small a or little a. Doesn't matter which way you say it. I have the good fortune of being your moderator for this evening. I am Dr. Elliot Brinton, past president of the American Board of Clinical Lipidology, currently serving as president of the Utah Lipid Center in Salt Lake City, Utah. And I have the great privilege and honor of introducing our lecturer, our instructor for this evening, Professor Carranza Leon, and she has a stellar biography, which I will share with you. She's an associate professor of medicine at the Division of Endocrinology, Diabetes and Metabolism at Vanderbilt University Medical Center in Nashville, Tennessee. She received her medical degree from Universidad Peruana Cayetano Heredia in Lima, Peru. Completed her internal medicine residency at UT Southwestern in Dallas, Texas. Completed her fellowship in endocrinology at Mayo Clinic in Rochester, Minnesota. Her primary clinical and research areas are management of complex cholesterol disorders and medical management of obesity. Dr. Carranza Leon is a diplomat of the American Board of Clinical Lipidology and the American Board of Obesity Medicine. In 2015, Dr. Carranza Leon received a Young Investigator Award from the Women in Endocrinology Society. Her qualities as an educator have been recognized as she has received the William D. Salmon Teacher Award from the Division of Diabetes Endocrinology and Metabolism at Vanderbilt University Medical Center 4 times, 2016, 2017, 2020, and 2022. Opus Medicus designates this course for a maximum of 1.0 AMA-PRA Category 1 credits and ABIM MOC points. Physicians should claim only the credit commensurate with the extent of their participation in the activity. Opus Medicus is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. One other thing, please. Any technical assistance you may need, put it in under Q&A. But also, as Professor Carranza Leon is speaking, you may type in questions under Q&A. Chat is disabled, so you won't be able to do anything with chat, but either questions, and you can put them in at any time during the lecture, or technical assistance, just put it in Q&A, and someone will help you if you need help. So without any further ado, it is a great pleasure for me to turn the time over to Dr. Carranza Leon, who's not only a wonderful and amazing physician, but she is an incredible human being and a dear personal friend. So, Professor Carranza Leon, the time is yours. Please go ahead.
Thank you, Elliot. You're very kind. So thank you, everyone, for joining us tonight to talk about lipoprotein little a. I think we are learning more about it, and I want to share what we know so far with you. These are our disclosures. So the learning objectives for today, the first one is to discuss the pathophysiology of lipoprotein little a and its pro-atherogenic effects. The second one, it's a more practical, more clinical. When should we be checking lipoprotein little a levels? We're going to review what current treatment we have, especially for those patients who are high risk, and in addition to that, have an elevated lipoprotein little a. And what is very exciting is that there are currently several drugs on development, specifically that will address patients who have elevated lipoprotein little a. So once again, this is a very exciting time to be in the lipid world, and I hope you enjoy what I have to share. And because I would guess most of the people that are joining me tonight are clinicians, I'm going to start with 2 patients which is who come to my clinic, to my lipid clinic. The first one is a 50-year-old female, and she was recently discharged from the hospital after she had a myocardial infarction. Before these hospitalizations, she was not taking any medications, and she went annually to visit her PCP. And at her last visit, we can see her results. Her total cholesterol was 193. Her triglycerides were 86. Her HDL was 32, and her LDL cholesterol was 135. Given that she had a recent myocardial infarction, she was started on rosuvastatin 40 milligrams daily. So she comes to your clinic trying to understand why, if she's 50 years old and her LDL cholesterol is reasonably not that high, she had this event. So the question here is if we should be checking a lipoprotein little a for her. And then if we do and we get a result, what normal is considered normal or elevated. And this is another patient, once again, that I'm sure you also see on your clinic. This is a 59-year-old male. He already has coronary artery disease, and actually he already had 2 stents placed. The first one several years ago, and the second one 1 month ago. And he also has hypertension. He had his first heart attack when he was 54, that is younger than you would predict. And his mom also had an open heart surgery when she was on her 50. He's currently taking rosuvastatin 20 milligrams and ezetimibe 10 milligrams. However, despite being on these 2 medications and having an LDL cholesterol, what we would call at goal, he still had an event. So you decide to check a lipoprotein little a. And these are his results. His total cholesterol is 122. His triglycerides are 159. His HDL is 31. His LDL is 59. And his LP little a is 161. So the questions I hope we can answer by the end of the talk are, is this level elevated? Is this high? Should we be concerned? And as a clinician, do I need to change anything on his therapy? And if so, is that something that is going to lower his lipoprotein little a? So let's start with what I say are the basics of a lipoprotein little a. So we're going to first discuss what is it? What is lipoprotein little a? The next point is, why is it important? I think that's one of the main reasons I'm giving this talk today. Then, once again, from a practical perspective, when should we check the level? And when we get a level, what are we going to consider a high risk value? So let's start. What is lipoprotein little a? As you can see here in the figure, it is an LDL-like particle that you see here on green, bonded to a structure called apolipoprotein little a, which are these beads and this rectangle here. Apolipoprotein little a is encoded by the LPA gene. And what is important is that it has 10 different subtypes of the Kringle 4 domain. And the reason why the Kringle 4 domain is important is especially for subtype number 2, because we're going to learn that most of us have more than 1 copy of this subtype number 2. What else is important about this particle? That it has a domain of oxidized phospholipids. It has a protein domain, a protease domain, and it also has a homology with plasminogen. So we were talking about the repeats of the Kringle 4 subtype 2, that being important. And the reason why this is important is because depending on how many copies of this Kringle you have is the length of your apolipoprotein little a. So here on this figure, you have 2 lipoproteins little a, one here with 8 copies of the Kringle 4 subtype 2, and another here with 40 copies of the Kringle 4 subtype 2. So why is that important? Because if you have a shorter number of Kringle repeats type number 4, if you have less of those are going to be secreted more efficiently by the liver. And that means that your patient is going to have a higher level of lipoprotein little a. On the other hand, the more repeats you have, these are going to be more susceptible to degradation, which is going to mean that your patient is going to have a lower level in plasma, of lipoprotein little a. So once again, this number of repeats, it's an important factor, and this will determine your patient's lipoprotein little a value. Lipoprotein little a is something that is determined genetically, and the inheritance is autosomal codominant. So that means that we inherit a form of lipoprotein little a from mom and one from dad, and at the end, our level is an addition of both of them. It reaches adult levels when we are about 5 years old, and then it stays stable throughout life. Something that is important that you share with your patients is that this level cannot be affected by lifestyle. So diet or exercise or any environmental factors are not going to change the level of lipoprotein little a. And most of the times our patients want to know what can they do to improve that level. And luckily, there is nothing so far that we know from a lifestyle perspective that will make lipoprotein little a low. Is there a gender difference? And there is a slight difference between lipoprotein little a for women and men. Women tend to have a higher concentration of a lipoprotein little a, and usually this level can increase some during menopause. In the case of men, once again, it remains constant throughout their life. And as I mentioned before, usually someone's level is kind of stable around since we are 5 years of age. Lipoprotein little a or LP little a is mainly synthesized in the liver. So if someone has hepatic impairment, their levels are going to be lower. And also the liver has been shown to be the main site of catabolism. The kidneys eliminate a small amount of lipoprotein little a, but any kind of renal impairment, even if it's small, is going to elevate the levels of lipoprotein little a. Inflammation is something else that can affect the levels. So please don't check this while your patient is having an acute infection because you won't get a true number. And then it's important to remember that when you get an LDL cholesterol on a lipid panel, it's going to reflect the cholesterol content of both LDL and lipoprotein little a. So in patients whose lipoprotein little a's are high, maybe the level that you get as an LDL cholesterol is higher than it really is. There are people currently developing formulas to try to differentiate on how to kind of subtract how much of the LDL cholesterol on a panel report is really LDL cholesterol, but we don't have nothing that we can apply clinically at the time. Why is it important? Why should we be measuring lipoprotein little a, and why are we trying to develop new medications? It is because now we're getting more information about the link between elevated lipoprotein little a and a cardiovascular disease, specifically myocardial infarction and stroke, and aortic valve stenosis. So this correlation, I think we're knowing more about it, and the more we know, the stronger it is. This is data from an observational cohort from the UK. And as you can see there, over 460,000 patients, most of which were white. And what they looked was if there was a relationship between the concentration of lipoprotein little a and the risk of cardiovascular disease. And as you can see on the figure, on the x-axis, we have the concentration of lipoprotein little a, and on the y-axis, we have the risk, and the relationship is linear. The higher the level of lipoprotein little a, the higher the risk of cardiovascular disease. Some studies have shown that for those patients who have a lipoprotein little a greater than 200, they have a lifetime risk of cardiovascular disease similar to someone who has heterozygous familial hypercholesterolemia. Also, studies have shown that patients with elevated lipoprotein little a have a higher risk for heart attack. And then even in those patients who are taking statins, like in this study shows, almost 30,000 patients on statins, those with a higher lipoprotein little a had a higher risk for cardiovascular disease compared to those who had a lower level. And why is this? Why is LP little a pathogenic? And I think there are different reasons that explain this. The first one is that LP little a is a pro-atherogenic molecule. And it does that by increasing small muscle cell proliferation. It also increases the amount of foam and cell formation. LP little a also has a pro-inflammatory effect by increasing oxidized phospholipids and different cytokines that you have listed there. And in addition to that, it's also prothrombotic. And that, in addition, all of these factors is what makes this molecule pathogenic and increases the risk for cardiovascular disease. So now we go back to the clinic. And the question is, when should we check a lipoprotein little a? And the way I have divided this is for patients that we already have an event or patients who don't have a cardiovascular event. So for those patients that you see in your clinic who already have a cardiovascular event, I would check a lipoprotein little a if they had an event when they were young, for men younger than 55 and for women younger than 65. And this would be like the patient that I presented initially, especially on those that don't have other risk factors to having had an event when they were young. Who else would I check a lipoprotein little a? On those patients who continue having cardiovascular events despite having an LDL cholesterol that we would say it's a goal. And the third group are those who had an ischemic stroke and they are younger than 55. How about those patients that do not have a cardiovascular disease? I would check an LP little a if they have a familial hypercholesterolemia, because that will help me determine if they have another risk factor for cardiovascular disease. On those patients that come to your clinic and they share with you that one of their family members, first degree, had a premature cardiovascular event, and maybe that's part of the information that we should have asked our first patient if she had any family members with premature heart disease. On those patients that have a calcific aortic valvular stenosis, and then for those patients that were doing primary prevention, and we decide to calculate their ASCVD risk, for those that are at borderline risk or intermediate risk, an elevated lipoprotein little a may help you decide if we need to start a statin or not. The European and Canadian guidelines are a little more aggressive, and what they recommend is to check lipoprotein little a at least once in all adults. When you're ordering a lipoprotein little a, you don't have to have your patient fasting, so you can do it at any time of the day whenever they come to their appointment. Something that is important that you know is that there is no global standardization in regards to the measurement, but there are two accepted tests that are going to be either mass concentration that is going to be reported as milligram per deciliter, or particle concentration that is going to be reported as nanomole per liter. It's important that you're aware of this difference because sometimes your patients come and they have their lipoprotein little a checked and they get one value in your clinic and then they would get another value somewhere else and they get confused and they are scared because their number was higher. And actually the difference has to do just with the units this was measured. A rough conversion factor that has been used is multiplying your result of milligrams per deciliters by 2.5, and that should give you a close enough level for nanomoles per liter. And now we go to the other part. So we already found out who are we going to check it. We know that we don't need to fast. So then once we get the result, how do we interpret what are high-risk values? And for that, this is again from that UK biobank cohort. And what they showed, here you have the median lipoprotein little a by race. And as you can see here in red, white had a lower median than patients who were Black that had a higher median. So that is important. And there are more studies looking into if we need to have cutoffs specific for race. But once again, we don't have that yet. And here on the right, we have the population's distribution levels of lipoprotein little a. And you see that most people have a level less than 100. And then as we go further to the right, the number of people that have those high levels decreases. So currently, some people think that a high-risk value is more than 50 milligrams per deciliter. That would be around more than 100 nanomoles per liter. And this is the 80th percentile for Caucasian people. Once again, the 80th percentile for African individuals from African descent would be higher than that. But as I mentioned before, currently we don't have any different cutoffs in regards to race. So what would I recommend for your practice? I think these are useful numbers to remember. If you check your patient's lipoprotein little a and it's less than 30, then we can say that this rules out extra cardiovascular risk. On the other hand, if your patient's lipoprotein little a is more than 50 or more than 125 nanomoles per liter, I would say this rules in cardiovascular disease. And then if the level is between 30 and 50, is kind of on the green zone, and that is when you need to decide with the patient what would be best for them next. So now we move into available therapy. So this is being recorded in September of 2023. And the reason I say the date is because available therapy for elevated lipoprotein little a may change in the future. So what do we have? If we have someone with an elevated lipoprotein little a, always we need to work on a management of non-lipid cardiovascular risk factors. So make sure that your patient's blood pressure, glucose is controlled, that they exercise, that they follow a healthy diet, and their weight is controlled. After that, we usually recommend to treat the LDL cholesterol or ApoB, and to try to target goals lower than with the statins, because remember, these patients may respond less to statins than your usual patients with elevated lipoprotein little a. Statins, the studies have shown that they increase the level of lipoprotein little a by 9 to 20%, and they do this by increasing the expression of apolipoprotein little a. Ezetimibe and bempedoic acid are medications that we use in practice, has no effect on the level of lipoprotein little a. And as I mentioned initially, lifestyle really has no effects on lipoprotein little a. How about estrogen? So estrogen replacement for postmenopausal women can lower lipoprotein little a by about 20%. And actually there was one randomized clinical trial that showed that by decreasing lipoprotein little a, it decreased the risk of cardiovascular events. And this was on a small sub-analysis. However, due to the potential of increased thrombotic disease, currently estrogen is not recommended to lower lipoprotein little a for cardiovascular disease prevention. How about niacin? So niacin as well, when used between 1 to 3 grams per day, it has shown to decrease lipoprotein little a by about 23% in a dose-dependent manner. And in the MHI clinical trial, what they did is they had patients who were taking simvastatin plus niacin or simvastatin plus placebo. And they showed that the group that was taking niacin had a reduction on lipoprotein little a by about 20%, However, this reduction did not transform to lower cardiovascular events. So given that niacin has many side effects and potential harms, once again, it is not recommended to prevent cardiovascular disease. And this takes me to PCSK9 inhibitors. So PCSK9 inhibitors have shown to decrease lipoprotein little a by about 20 to 30%. And it's thought that it may reduce the concentration of lipoprotein little a by increasing clearance and a decreasing production. And here you have the summaries of the outcome studies for the both PCSK9 inhibitors that we have available. Fourier for evolocumab and Odyssey for alirocumab. And as you can see, these were patients who had cardiovascular disease in both studies. These PCSK9 inhibitors were able to lower lipoprotein little a by about somewhere between 23 to 27%. So if we go and review what did each study showed for each of these medications, Fourier, that was the study with evolocumab, showed that those patients that had a higher baseline lipoprotein little a had greater cardiovascular disease. And actually, it showed a reduction on the number of cardiovascular disease, especially on those who started and who had a higher lipoprotein little a to begin with, and the change on lipoprotein little a was also higher. Alirocumab, which is the other PCSK9 inhibitor that we have available, showed similar results. Higher baseline lipoprotein little a was associated with a greater cardiovascular disease risk. And once again, alirocumab decreased the number of cardiovascular events, especially in those patients that had higher lipoprotein little a's to begin with. And those patients had a larger reduction on lipoprotein little a. And something important that they showed as well is that this reduction on cardiovascular events was independent of the reduction on LDL cholesterol. And now we move on to a lipoprotein apheresis for elevated lipoprotein little a. This is currently the only FDA-approved treatment for lowering a high lipoprotein little a. For those of you who have sent your patients for lipoprotein apheresis, you know that this is an acute reduction on lipoprotein little a of about 55 to 80%. And as we're going to show on a retrospective and prospective study, there has been shown that there are decreased cardiovascular events on patients with elevated lipoprotein little a who undergo lipoprotein apheresis. Overall, this is well tolerated. As you can see, there are a few side effects such as access problems, hypotension, chills, fatigue, or nausea. And the cost is about $50,000 per year here in the US. So what happens with patients that have regular sessions of apheresis is that here with my cursor, you can see that they start at a very high level of lipoprotein little a. And as they go through the sessions of apheresis, their baseline lipoprotein little a lowers with time, which is a good thing so that they have a lower baseline value. Germany is one of the countries that is ahead on this. They approved lipoprotein apheresis in 2008 for patients with an elevated lipoprotein little a who had progressive cardiovascular disease. And then here in the US, as I mentioned, the FDA approved lipoprotein apheresis in 2020. So this report shows us what they have found during 8 years on these patients who were going to sessions of lipoprotein apheresis. Something that is important to mention is that these people had sessions once a week. Here in the US, most of the times our patients have sessions every 2 weeks. So what they looked was what were the number of cardiovascular events before they started apheresis and after they started apheresis. And that is what you have here on these figures. So on the left, you have when they started a lipoprotein apheresis. So the red would be before lipoprotein apheresis and the green after lipoprotein apheresis. And it's important to mention that these were patients that at baseline had an LDL cholesterol less than 100 and a lipoprotein little a more than 60. So here the indication for apheresis would be the high lipoprotein little a. And you can see here the dramatic decrease on a cardiovascular events after they start lipoprotein apheresis. Here on the right, these are for non-cardiac events, so mainly stroke, on orange before apheresis, and on green once again after apheresis. And you can still see a significant decrease on the number of events. So once again, here in the United States, the FDA approved the use of lipoprotein apheresis on patients who have familial hypercholesterolemia and have a lipoprotein little a more than 60. However, in addition, they need to have an LDL cholesterol more than 100. And they, of course, have to be on maximal phosphorylated therapy. In Germany, they only have to have the lipoprotein little a more than 60. It really doesn't matter the LDL cholesterol. The main factor is that they have to have progressive cardiovascular disease or events despite control on other risk factors. And what the American Society for Apheresis is recommending is to have apheresis on those patients who have an elevated lipoprotein little a with a cardiovascular disease. So prices, once again, this varies, but it can be per session somewhere between $1,600 to $4,400 per session. And majority of the cost is for the disposable columns that are used, but as you can see, there are additional costs as a physician, nursing time. And then once again, most private insurance cover, Medicare also covers it, and once again, reimbursement just depends on each institution and each different insurance. So with that, I'm going to move to upcoming treatments for a lipoprotein little a. And as I mentioned before, this is a good time to be on the cholesterol world, given all the new therapies that are becoming available. So the first treatment that I'm going to talk about is called pelacarsen. Pelacarsen is an antisense oligonucleotide. So the way it works is here you have the antisense drug that goes into the nucleus, and it binds to the mRNA. And in this case, it binds to the mRNA of a apolipoprotein little a. And this complex is recognized by these RNAs, and this cleaves, and therefore there is no production of a apolipoprotein little a. Pelacarsen is a medication that is given subcutaneously once a week, and it has a long half-life of about 1 month. And studies have shown that it lowers apolipoprotein little a by about 70 to 80%. Something that is important and that has been done with time is that they have been able to attach this GalNAc complex that makes this molecule more specific to the liver, which has helped lower the amount of doses that patients need to receive. So the phase 2 clinical trial for pelacarsen, they had 6 different treatment groups with 6 different doses. And the goal was to look at percent change in a lipoprotein little a. And this is what they found. They found here you have in a gray, the placebo arm, and all of the other arms are different doses and different frequencies of pelacarsen. And you can see depending on the dose or the frequency that they use, they will decrease lipoprotein little a somewhere between 35 to 80%, which is very significant. In regards to side effects, there was no difference between the treatment group and the placebo group. And usually the most recent or the most common reason to stop the medication for those who were receiving pelacarsen was muscle symptoms, myalgias or arthralgias or injection reactions. Currently, the LPA Horizon study is being conducted, and we hope that the results of this study are available sometime next year. And this is the outcome study of pelacarsen. So these are patients who already have cardiovascular disease, who have a high lipoprotein little a, and they're going to see if lowering lipoprotein little a with pelacarsen decreases the number of cardiovascular events. The next two medications I'm going to talk about are small interfering RNAs. And here, the way they work is these molecules, you have two strands, both of which go into the nucleus, and then they come apart. And one of them binds to the mRNA of apolipoprotein little a again. And this now it's targeted by an RNA-induced silencing complex, and that is how we don't make the protein anymore. So olpasiran is one of these small interfering RNAs that targets a lipoprotein little a mRNA. It's also administered subcutaneously and also has this moiety that has been attached so that it's more specific to the liver, and it prevents the synthesis of apolipoprotein little a. The Ocean dose trial was another phase 2 studies where they used different doses, 4 doses, to see the effects of this medication on levels of lipoprotein little a. And this is what they showed. Similar to the other study here on gray, we have the placebo group, not a big change. But then we can see here even more reductions of lipoprotein little a, somewhere between 70 and 90% reduction on the levels of lipoprotein little a. Side effects, similar to the other molecule, not a big difference between those on placebo and on the treatment arm. And once again, the main reason to stop the medication would have been injection site reactions compared to placebo. And this molecule also has an outcome study that is currently ongoing. And once again, similar patients who have an elevated lipoprotein little a, who have a cardiovascular disease, and they are looking into if lowering lipoprotein little a would decrease the number of cardiovascular events. The next two medications I'm going to talk about are still on phase 1. And this is another small interfering medication, once again, blocking the production of a lipoprotein or apolipoprotein A. And here I'm showing you the results. And once again, this is a phase 1, so very short study. And you can see how, depending on the patients and the doses, how much it lowers lipoprotein little a. And once again, as we saw with the other one, somewhere between 40 to 80% reduction. So currently the phase 2 study is being conducted to try to find a dose that is going to be helpful overall, lowering lipoprotein little a. And this just came out a couple of weeks ago on JAMA. And it's actually the newest molecule we have to lower a lipoprotein little a. This protein is interesting because it's an oral molecule. The other ones that I was talking about are subcutaneous injections. So that is important. And the second one is that it works in a different mechanism. What it does, it avoids the binding of apolipoprotein A with ApoB. So if these two cannot bind, we are not going to be able to have a lipoprotein little a. So once again, the results that were published a few weeks ago were from their phase 1 study. And what they showed is that on these healthy volunteers, when they received this medication, there was a decrease of a lipoprotein little a of about 50%. So now let's go back to our patients. And let's see if we can answer those questions that I initially posed. So remember, the first patient was this 50-year-old female who had a recent myocardial infarction. And before the hospitalization, she was not taking any medications. So maybe something that would have been important here to ask if she had a family history of a premature heart disease. And you can see here her LDL cholesterol is 135, and she's taking rosuvastatin 40 milligrams daily. The first question that I have here is if we should be checking her lipoprotein little a. And I hope I have convinced you that the answer is yes, that we should be checking her lipoprotein little a, given that she had a premature event with a not that abnormal LDL cholesterol. And then the next question that I had here is what would be considered normal or elevated lipoprotein little a? Once again, that number would be the more than 50 for the lipoprotein little a. So if you checked her lipoprotein little a, and the 50 is for milligrams per deciliter. And then for the next patient, this is a gentleman who has coronary artery disease. He had a second event despite being on rosuvastatin and ezetimibe, which seems appropriate therapy. And you check his lipoprotein little a level. So the first question here is his lipoprotein little a elevated? And the answer would be yes. Remember, the number for milligrams per deciliter is 50, so his number is elevated. And then the next question is, do we need to change or not his medication therapy? And I would say the answer here would be yes as well. And here, what I would do is I would talk to the patient about the two options that I can currently offer. One would be to start him on a PCSK9 inhibitor and see if that lowers his lipoprotein little a. As I mentioned, usually those are more effective for patients who have higher lipoprotein little a. I'm sure, like I have, sometimes I put patients on PCSK9 inhibitors and their lipoprotein little a does not change much. So it's variable, the response we have. And of course, something else that we could offer is a lipoprotein apheresis. But as you all know, this is a life commitment. They have to go to the sessions every 2 weeks. But that's another option that this patient would have. So with that, I want to summarize what we have talked about today. I hope I have convinced all of you about the strong relationship between a high lipoprotein little a and a cardiovascular disease. Also, we discussed who are candidates for a lipoprotein little a testing, and for sure those who are at high risk of cardiovascular disease. Lipoprotein apheresis is currently the only FDA-approved therapy for elevated lipoprotein little a. And once again, it should be recommended to some high-risk patients. And in the horizon, we have at least 3 different classes of medications that are currently under investigation as potential tools to lower lipoprotein little a. For us in the lipid world, it's very exciting to see all the new data that is coming out. And I think if those outcome studies show a positive result, that there is a benefit of lowering lipoprotein little a, it's really going to be a game changer on what we do. And with that, I'm ready for any questions that there will be.
Magnifico. Gisela, that was great. Thank you so much. So you can see the way to get the credits. And let's go ahead. I think we're going to take the questions just through the Q&A part here. We don't get to take verbal questions, audio questions. But while we're getting those questions in, I have a question for you, Gisela. That, again, was really wonderful. I just appreciate the way you went through that, so many different details that are all clinically important. How is it that you decide when to refer somebody for lipoprotein apheresis and when you don't? And before you answer, let me just point out that not only do we have these amazing data from every week in Germany, but there's a series from the US where we do the apheresis every other week. And in that series, it was actually a 94% event reduction. So it's really pretty remarkable. How do you decide when to talk to your patient about apheresis? Is there an apheresis center there in Nashville, and how do you know when to refer the patient?
So yes, so at Vanderbilt, we have an apheresis center that is run by nephrology. So we refer the patients to their center to do it. So yes, that's available. And actually, I have a couple of patients doing lipoprotein apheresis for lipoprotein little a specifically. So I think the two things I think is that patient that continues having events despite having an LDL cholesterol in theory at goal. And I usually give them the option, once again, as I mentioned on the case, PCSK9 inhibitor or apheresis. As you can imagine, as I mentioned, doing apheresis is a life-changing because you have to commit to blocking 4 or 6 hours of your day for every 2 weeks. However, it's going to be good overall for your health because it's going to prevent events. So it's just a discussion. But on those patients that I have patients who, despite being on a PCSK9 inhibitor, like being on everything I have, they continue having events. Those are the two patients that I have currently doing lipoprotein apheresis. And so far, they haven't had any events. But once again, and of course, we have to go through insurance, which can sometimes be a hurdle. Sometimes some insurance are more understanding than others, let's put it like that. Sometimes the number of paperwork you have to do is 1 page or more than one. But on these two cases, I think we were able to make a good case and it was approved and they are doing that.
Good. And of course, you mentioned it's a commitment. It isn't really a lifetime commitment in the sense that I think as we get the cardiovascular data from these newer drugs, if they show benefit anywhere near what we see with the apheresis, then of course we could always switch them over. So we can be flexible with the treatment. So that was excellent. Let's see. I guess I better go into the Q&A at this point. We see no open questions. While we're waiting for more questions to come in, and please go ahead and type in questions. I have another question for you. Gisela, how do you decide when to measure Lp(a)?
So I think, and that is a question actually that I have been thinking about because one of my colleagues said, who should be responsible for checking lipoprotein little a? Is this more like a primary care provider who should be checking it at least once? Should it be the cardiologist? As you know, I'm an endocrinologist, but I work in the lipid clinic. So I think it has to be when the patient comes to your clinic and if they continue having recurrent events, or they tell you know what, my mom had a heart attack when she was 50, and you look at their lipid panel, and they really don't have FH, then you need to think, what other risk factor they have that I can measure to try to explain why this patient had premature, the family member, the first degree family member had an event. Also, when you're trying to do risk stratification, like on those patients that you don't know if they need to be on a medication or not, a high lipoprotein little a can be something that can tell you, you know what, I think you need to be on a medication despite your risk being like 6% or 6.5%, according to the calculator.
Very good. We do have a question here in the chat, in the Q&A, sorry, not in chat. There's one question in the Q&A. What is the role of genetics clinically? And I guess let's maybe address that in the context of what you've been talking about this evening, and that's lipoprotein little a. Is there a clinical role for genetic testing or for genetic modulation of Lp(a) levels?
So those are good questions. So the first one is, as I mentioned, this is something that is genetically determined, and really the levels, the way the inheritance work, I think it's very interesting because it's not like you just get one gene and that is what is going to give you the level. Is you inherit a certain amount of lipoprotein little a from your dad that can have like 8 copies of the Kringle type 2. And then you inherit another amount from your mother that can have 100 copies from the Kringle type 2. And at the end, your level is going to be an addition of both of that. And that is how you get your total number. So clinically, I haven't seen really people use to do a genetic testing for the LPA gene, or it would be for the apolipoprotein gene. I don't know, Elliot, if you have any thoughts there. And the other question is genetic therapy. I think that is going to be coming. Like if we find that the outcome studies showed, I started doing lipids about 80 years ago. And back then, PCSK9 inhibitors had just come out in 2015. And we, people that did cardiology or lipids or endocrinology, were so happy to have a drug that was a monoclonal antibody. It was the first time that we usually had like enzyme inhibitors. We didn't have a monoclonal antibody. So now we are 80 years later, and now I'm talking about nucleic acid therapy with the antisense drugs and the small inhibitor, small RNAs. So I would not be surprised if we get to find that this is really something that if we have lower levels, we can improve people's cardiovascular health. As they're working on gene therapy for familial hypercholesterolemia, I think maybe gene therapy for elevated lipoprotein little a is something that could be available in the future.
Yes. And just to comment on your comments, we already have the one remarkable treatment, which is lipoprotein apheresis, with a spectacular drop in events. As you presented the data of these drugs in development, they're amazing in terms of the degree of Lp(a) lowering. It's 60, 70, 80, 90, 100%. Doesn't get any better than that. We've got that oral agent that's in early stages, very, very exciting. And then just to comment on the genetic question, I don't actually do gene testing for ApoA because, as you pointed out, you will get two alleles and they may be matched or not matched. But what really matters apparently is the overall level. And there have been some studies where they compared genetic testing of ApoA, the ApoA gene, versus the phenotypic checking of the Lp(a) level. And it doesn't seem that the gene testing adds anything to the prediction of cardiovascular disease risk. So I personally don't do it, and I don't think it's being done very widely, although, of course, there is an argument to be made in favor of that when you're talking about FH, familial hypercholesterolemia, which can be seen with elevated Lp(a), but it's, of course, a separate question clinically. And again, we are open to questions. If somebody would like to go into the Q&A and type something out, it takes just a minute, but we would love to have your questions. Here's another question, and that is, what do you do if you have somebody who's the only thing that's elevated is their Lp(a)? So they've not received any treatment, let's say, and their LDL is normal without treatment, but their Lp(a) is high. What do you do if they've never had an event? And then maybe another question would be, what happens if they have had an event and the only thing that's elevated is that Lp(a)? What would you say to this group?
So I think, let me start with the second patient. This is actually, I think, an easier answer. So if someone already had an event and their lipoprotein little a was high, I would be more aggressive on the lowering of his LDL cholesterol. And that is where I would think, depending on how many events, if it's the first event, if he had recurrent events, PCSK9 inhibitors, lipoprotein apheresis. So I think that is the one that I think most of us would agree with. As soon as you have someone, go ahead.
Let me just interrupt for 1 second. What would happen if, their LDL, let's say, starts out at 50, and you're going to treat LDL aggressively because of the high Lp(a), and I think that's a great idea. What do you think, or what happens if their LDL goes, say, from 50 down to 20 or 10 or 5? Does that worry you?
It doesn't. Like I think initially, when all of this started, the cutoff that we had was like 25. That is when I would get a little kind of, I haven't seen 25s in a long time, so let's be careful. But I think the more data we have is that lower is better. So if I have a 10, a 15, I don't have any trouble with that. And then remember, we always need to do the direct LDL, because sometimes the formula, and I'm sure the same happens to you, they say LDL cholesterol negative 15. It's not negative 15. It's just that the formula is not helpful there.
And so if we're doing aggressive LDL lowering, either with medications or perhaps we're going to do lipoprotein apheresis, I think it's important what you've said. Don't worry if the LDL drops to 0 or 5 or 10, because that's actually a little bit better than 20, even though, of course, we don't have goals in that area. Now, what about the other case? So here's somebody without a prior event, and they have a normal LDL, but they have a high Lp(a). What would you do?
And actually, believe it or not, that's a patient that came this morning to my clinic. It was someone who's, and I think the answer may change, like I can always make a second case. That patient with an LPA, a lipoprotein little a of 150 versus a lipoprotein little a of 60. So I'm giving, like, if you have someone like the patient that I had today had a lipoprotein little a closer to 200. LDL was normal, no events on him. I think his grandmother had a stroke when she was younger than 65. So then the question is, what do I do? So the conversation I had with my patient today is, number one, all of the data we have is for patients that already have an event. Like if you see the population of patients that are being studied, this is not primary prevention. This is already patients that already had an event. So I'm telling him, I don't have data for patients like you who have never had an event. However, I know that a higher lipoprotein little a from the data that I showed from that UK cohort, a higher level is higher risk. So what I would recommend is starting a medication to, once again, lower LDL cholesterol. And the discussion that I had with him, and actually the reason he came to see me is because he had already had trouble taking statins. And we discussed about starting a PCSK9 inhibitor here just to decrease the level because his level is so high. And as I mentioned on my talk, usually these patients with higher lipoprotein little a's are the ones that are going to have a better reduction on a lipoprotein little a and of course on risk. I don't know if the insurance is going to go with me in regards to the medication. And if it doesn't, most likely I'm going to put him on a ezetimibe, given that he did not tolerate statins. And that is what I would do. And with someone who has a lipoprotein little a closer to the what we consider high, that is this 50, that once again, it's something that it's there because it's the 80th percentile, I would once again would try to lower their LDL cholesterol. First, always with the statins, even though they raise lipoprotein little a little, I think it's still our best bet to start with.
And can we go into rapid response mode? Let's see if we can squeeze two quick questions in before the end of the hour here. What do you think about Lp(a) elevation and ischemic stroke? Do you want to just address that very, very briefly, specifically? And then I've got one more question.
It is associated. There is a risk between high lipoprotein little a and ischemic stroke. And actually, that's another patient that came to my clinic today.
And of course, it also occurs even in young people. If a teenager has an ischemic stroke, they may well have a high Lp(a) as their cause. One more very quick question. Depending on the age of the patients and perhaps family history, would you consider calcium scoring, so coronary artery calcium by CT, in those with low LDL but elevated Lp(a) before starting on a statin therapy? Do you find any role for coronary calcium?
I think it could help you once again if it's someone who has a normal LDL. So this patient that came to see me that I was talking, he already had a calcium score that was 0, but that didn't made me not try to treat him because I already know that the lipoprotein little a is high. So it can help you. If it's high, that would be another reason to treat a patient. But if it's 0 and you have a patient with a very high lipoprotein little a, I would not make that dissuade you from starting therapy.
That's a great point. And by the way, according to the FDA approval of apheresis for Lp(a), they will allow us to document coronary atherosclerosis by coronary calcium. I've never done it in the absence of a prior clinical event, and I don't know if insurance would approve, but that is on the list. So with that, we're at the hour. Gisela, this has been really terrific. You've done a great job with the presentation, great job in fielding a lot of interesting questions. Thank you to those who've asked the questions. Again, we have the CME available. And so I wish all you well. Thank you for dialing in. And with that, on behalf of Opus Medicus, I want to thank you for being with us. And I hope you have a great opportunity to recognize and treat those high Lp(a) levels. Thank you very much.